So I would like to introduce our next speaker, Dr. Martin Minich, who has a special interest in regional anesthesia and is into medical education. And he has a role of setting up the non-operating room anesthesia in the University Hospital of Coventry and Warwickshire, where he works as a consultant. And he's going to tell us how it works in the UK and the problems people face in setting up a NORA and the uh, challenges in providing safety in a remote area. So Martin, over to you. Thank you.
Thank you for that introduction, and thank you for inviting me to talk at this webinar this evening. My session is based around exploring some of the barriers to setting up an anaesthetic service in a non-theatre area. I'll share with you some of the solutions I've found, along with some of the things I wish I'd known about earlier on in the journey that would have made life a little bit easier further down the line. I'll be drawing heavily on my own experience of the setting of interventional radiology, which is the main non-theatre area in which I work. However, many of the themes are common to other non-theatre areas, so hopefully there'll be something relevant to your area of practice. It's important to acknowledge from the outset that I'm on a journey and I'm not an expert. There'll be many of you watching who have more experience of working in non-theatre areas than I have, and I definitely appreciate your input a bit later on down the line as part of the Q&A session to help benefit the wider audience from your experience. However, my experience is recent enough and ongoing to hopefully provide some useful and relevant information to those about to embark on a similar journey in your trust. My involvement in anaesthesia for radiology started about 6 years ago when I was asked to be lead anaesthetist for MRI. This involved working with radiology, neurology and neurosurgery to set up a regular elective outpatient MRI service for patients who, for whatever reason, were unable to have MRI scans without a general anaesthetic. We were making good progress towards this service until COVID struck and completely derailed our service, just as it derailed many other NHS services up and down the country. In the wake of the first wave, when our trusts were deciding about prioritisation for restoration of services, as you'd expect, our GA MRI service had a pretty low priority on their list. However, something which did have a high priority was exploring less invasive treatment options for patients with significant pathology. Imagine you're unfortunate enough to have a liver tumour, for example. One treatment option would involve open resection. This involves epidural analgesia, prolonged utilisation of theatre space, HDU care post-operatively, and a number of specialties and services involved in your care while you stay in hospital for a few days post-op to recover. Very resource intensive and utilising critical care capacity that wasn't necessarily there at the time. An alternative for some tumours would be to treat them with percutaneous ablation therapy. This can be done as a day case, requires either a very deep plane of sedation or general anaesthesia typically, but the patient can go home 4 hours later with some paracetamol and some codeine, and we have the option of treating several patients in one day. Very appealing. However, the support just wasn't there pre-COVID. So I was asked to try and set up a service whereby we could support this on a fortnightly basis, and a business plan was pushed through in order to achieve this. Over the next 20 minutes or so, I plan to share with you some of the barriers I encountered as part of this journey and some of the solutions we found. By far the largest barrier to non-theatre anaesthesia I find is staffing and enthusiasm among staffing. If you were to turn up to work and were to be told that your planned elective theatre list that you'd prepared to do, colorectal, gynae, max fax, whatever, was cancelled because of surgical sickness or lack of bed availability. However, there was an interventional radiology list that needed covering, or an inpatient who needed an urgent MRI scan from the wards under general anaesthesia, most people would have one of two responses. The first response might be that it's a bit of adventure. It's a change to the routine. It's something different, and you might embrace these new challenges. However, at least internally, a lot of people's first response would be something like this: slightly less keen on the plan. And for some reason, we as anaesthetists can have this initial reaction to providing anaesthesia outside of theatre. And it's not that we're reluctant to provide anaesthesia outside of theatre, it's just that we probably really enjoy providing anaesthesia inside theatre. The reason for that? We feel very comfortable. Everything is set up for us. It's all there. The patients come to us, we have an anaesthetic room, we have some control over the environment and the session. Everything we need is there: cannulas, drugs, equipment. The patients move through the theatre complex and the flow is pretty logical. They stay and they're looked after by a range of different practitioners, including ourselves and the theatre recovery team. And when they're ready to be discharged to the ward, we can see them, and we can be quite happy that our process is complete and that our patient is safe. However, when you're outside of theatre, that logic flow through the anaesthetic and the perioperative pathway doesn't always exist, because these non-theatre areas haven't been designed for us to work there. So it requires a lot more planning, a lot more forethought, and we have to be prepared for a range of eventualities. In theatre, we have help and support at the drop of a hat. When we're in a completely different part of the hospital, in interventional radiology, for example, that support will take a lot more time to come. So we have to be a little bit more alert. Take, for example, the simple task of siting a cannula. If you have to site a cannula for your patient in the anaesthetic room, it's really straightforward. Everything's there, the cannula's there, the dressing's there, the assistant is there, not a problem. If, however, you're asked to pop up to the ward to site a cannula for a patient with difficult access or whose cannula's tissued, it's a very different game, isn't it? You have to either bring equipment with you, or you have to hunt around on the ward for every single thing. You usually don't get the assistance that you'd have had in theatre, and everything's just that little bit more complicated. We like theatres, we like our anaesthetic rooms, they're very convenient. So therefore, we should expect barriers when we're providing anaesthesia outside of the theatre environment. And depending on the type of person we are and the way we work, we may adapt and be pragmatic to this very easily, or it may be a little bit more difficult for us. I've already mentioned that the biggest barrier I find personally is related to staffing. So I'm going to explore that a little bit more now. Let's think about the staffing numbers that are sent to support non-clinical areas, non-theatre areas, sorry. Often, the bare minimum are sent. An ODP and an anaesthetist are sent out into the wild to support ECT or cardiac cath lab or radiology. Whereas in theatre, there's an abundance of staff often to cover for breaks, allow for rotation of theatre teams. It's a very different way of working. We have to remember as well, we are not the only person who feels outside of our comfort zone in a non-theatre area. The ODP might be feeling exactly the same. So if you're planning a sustainable service where staff are going to want to work in this non-theatre environment, then you have to provide some replication of some of the theatre conditions. So our team in radiology is a consultant anaesthetist, an ODP, a recovery nurse who's often able to work as an ODP as well, as a lot of our team are dual trained, and a support worker. And in that way, we have a larger team, more akin to the theatre environment. Nobody feels completely by themselves, and we have people who can move between the theatre and the non-theatre environment to pick up that one thing that you inevitably forgot. However, the number of people isn't always the most important thing. The type of person and the enthusiasm of the person is probably just as important. We want more Frodos than we want toddlers, essentially. We want people who can become experienced and enthusiastic to develop these non-theatre area and to train others. So initially, when we started with our radiology service, we had a very small group of anaesthetists and ODPs who would work in that area. We asked our ODPs if anybody was interested in becoming a champion for radiology, and we had interest, and Linda, one of our ODPs, took that on board, and she's essentially become lead for this area. She's been instrumental in a lot of the QI projects that have gone on there, and in supporting other ODPs working in our environment as well. So from the outset, a very small group of people is very useful in order to create protocols, see how things work, and get an idea about what can be done and what can't be done safely. But after that, it's important to expand the group quite quickly, because nothing works as a one-man band. We really do need to have more anaesthetists and more ODPs working in these environments. So it's important the initial group is small and enthusiastic so that they can help support future colleagues come into those areas. And there's a couple of things which provide motivation. So obviously cake and free lunch and things like that provide motivation, but other things that provide motivation is learning about outcomes and getting feedback. So these lists seem like a lot of effort to put in for the ODP and anaesthetists who are doing them. It's really important that they're aware that this is very worthwhile work, and finding out some of the outcomes from the patients that pass through the service helps provide some motivation moving forwards, and relaying this information at quick meetings, obviously within the realms of clinical governance, is a very useful motivating factor, as is feedback. So feedback from the radiology team, feedback from patients, their families, their carers, and feedback from the anaesthetist to the ODP and vice versa is very useful for driving change and providing motivation in this area. But why do some people feel less enthusiastic about working in this area, and what can we do about them? So I've certainly experienced it, and I'm sure some of you have as well, that when you're working in a non-theatre area, you can feel a little bit isolated. You can feel that you're working in someone else's workplace, or that you're just a visitor to another team. In the theatre environment, we're very used to having a bit of authority, a bit of power, a bit of control over our workload and our environment. And sometimes that's missing when we're in a non-theatre area. So it's really important that rather than working in these silos, there's some element of mixing and integration of the teams. Something as simple as an induction to the area for new anaesthetists or ODPs who haven't worked in the area, showing them where the cough rooms are, the toilets, the changing rooms. I found out quite recently that one of the ODPs who comes to radiology not infrequently would go back to theatres to use the bathroom if she needed to, purely because she didn't know the combination to the changing rooms in radiology. So it's important that people feel welcome and people feel part of the team. That way they'll be motivated and be happier working in that environment. In terms of a lead role, I attend the interventional radiology resource planning session on a monthly basis. This is incredibly useful for feeling part of their team and giving a point of contact for them to talk to me as well. I find out about the things which are relevant to the radiology departments, find out about their critical incidents, about their quality improvement projects and the things that are going on in the department. So if you're wanting to merge and work collaboratively, that's a really useful thing to attend. You also become much more of a familiar face in that way, particularly if the radiology session is 1 day a week or 1 day a fortnight. There'll be lots of people that don't work on that specific day, so in order to get to know the full department, it's important to attend these other sessions. So we've contemplated staffing as one of the key specific barriers, but that's obviously not the only barrier. When I think about the barriers, I've divided them into these key headings. So staffing we've talked about, procedural factors, patient factors, environmental factors, and in that we include some elements of positioning, issues relative to pre-assessment, and issues relative to recovery, and some issues relative to patient ownership. So we're going to talk about those in turn for the rest of this talk. First thing to consider is procedural factors. When we're working in theatre and we get a copy of the operating list, we're very familiar with the cases and the operations on that list. Now that might not be true when we're in a non-theatre environment such as radiology. If we have a patient on our list having a lap chole, lap appendix, an abscess, hemicolectomy, something like that, then we've seen these procedures before. We've anaesthetised the patients that have these procedures. We're aware of the kind of pain the patients are in post-operatively and the kind of pain relief options that are available to us to help manage and anticipate this pain. We're also aware of critical points during the operation where we as anaesthetists can influence surgical operating conditions, and we can help or hinder our surgical progress. This might not be true and intuitive for our radiology procedures, and it might be that we just have to be very frank and open with our radiologists and explain, this isn't something I've seen before. Can you tell me exactly what you're going to do? How long is it going to take? What kind of pain is the patient likely to be in post-op? Are there any specific things that you want me to do, such as allow the patient to have some breath holding at certain key points during the procedure? What position do you want the patient into? And we'll come back to that in a second. Often this is an entirely new selection of procedures, and us as anaesthetists will struggle with that, but our ODPs may also struggle as well. They're used to being prepared for every eventuality, and they don't like the situation where they might not be able to provide you with what you require. So it's very useful pretty early on to set up a list of things that are needed for all cases and things that are needed in specific cases. For example, if you had a patient having a TIPS procedure, you might indicate that you needed invasive monitoring for that. Or if you had a patient that required a CT guided kidney ablation, then you might need to prepare the ODP to get some equipment to allow you to prone the patient, such as Montreal mattress, firm head support, reinforced tube, etc. So creating a list of things which are needed to run the list and a list of things which are needed for specific procedures would be very useful in that circumstance. And what kind of procedures are done? So one of the most common procedures that we do in interventional radiology in Coventry are ablations of tumours. So kidney tumours, liver tumours, and the two are very different. Liver tumours tend to be done under ultrasound guidance, take 20 to 30 minutes, involve a laryngeal mask, supine position, and some pain relief for the post-operative phase. Renal ablations, however, often involve a CT-guided approach. The patient will have to be positioned prone or lateral, and all the incumbent risks and associations and complications evolve with that will have to be taken into consideration. As well as ablations, we do a lot of stents, we do some embolizations, we do some angioplasties, and we do some diagnostic imaging as well for patients unable to tolerate the imaging with them awake. So when you're introducing a whole new range of procedures to a theatre team, it's useful to have these resources available and to provide some face-to-face teaching sessions at QI meetings, etc., to allow people to ask questions and find out more about why patients need these procedures, what the procedures involve, what we need to do to help support the radiologist during the procedure, and how the patient will be in the post-operative phase. Next things to consider is the patients having these procedures. So broadly speaking, you can think of the patients that require anaesthetic support for interventional radiology as falling into two groups. So the first group is for patients having a procedure that is not possible under local anaesthesia or sedation, as most radiology suites up and down the country are able to provide nurse-given sedation. The second group are patients unable to tolerate the procedure under local anaesthesia or sedation, but a procedure that wouldn't normally be done under local anaesthesia or sedation. And this tends to be a more complicated patient group. So this includes patients with learning difficulties, movement disorders, patients for whom position is limited by pain, patients with severe anxiety or severe claustrophobia, patients requiring organ system support, or patients in whom sedation has been deemed unsafe, such as patients with severe obstructive sleep apnea, for example. And it's these patients that pose the larger problems. So although the procedure may be relatively non-invasive and potentially a straightforward procedure, the anaesthetic might be the more complicated factor. And it's important to remember that even for minimally invasive procedures, the anaesthesia still needs to be appropriate for the patient's comorbidity. One big issue in these patient groups and in patients having diagnostic imaging is consent. Whose job is it to take consent for an MRI under general anaesthesia, for example? Is it the referring team or the anaesthetist? Now, logistically, this can be a very difficult thing to manage. I mean, the referring team may not be present on the day, for example, if the only intervention is the general anaesthetic. For the patient with severe learning difficulties, it may not be feasible for them to attend hospital twice, once for a best interest meeting and consent discussion, and a second for the scan. In fact, it may be harmful if the first visit generates bad experience and memories, then they may not be keen to attend for the actual scan itself. And the issues of consent and how to arrange consent for diagnostic imaging was a big factor in the early days of our MRI service. In 2019, the Association of Anaesthetists produced this guideline for the safe provision of anaesthesia in MRI units. And there was a paragraph in there which addressed consent issues. It acknowledged that for diagnostic scanning, the only intervention is the anaesthetic, but the referring clinician or radiologist is responsible for seeking formal written consent, as they will have discussed other options, including not performing the imaging and the impact on diagnosis and prognosis of that omission. Our role is to explain the anaesthesia to facilitate the scan, although just in the context of surgical anaesthesia, we're not required to provide formal written consent separate to the surgical consent form. Often there are issues with patients referred from other hospitals, and there should be procedures in place in order to prevent delays on the day, if that's the case. However, the guideline is a bit pragmatic, and it specifies that in exceptional circumstances, the anaesthetist may provide consent for the scan itself if they understand that the reasoning for the imaging that's been undertaken. One of the advantages of COVID, if you can call it an advantage, is people's familiarity with virtual meetings. And this has revolutionised best interest meetings for the purpose of consent for diagnostic imaging for us. It allows a meeting to occur several weeks before the intended scan day. Everyone who's necessary to attend can be there, so family, the patient, carers, any IMCAs or IMHAs involved in their care, community teams, GP, referrer, and us as anaesthetists. It allows us to discuss ahead of the time any best interest issues that may be related to the scan itself, and confirm that the scan is being done in the patient's best interest. Allows us to talk about the consent process and do any relevant history taking. And it allows us to think about any reasonable adjustments that may be required to the standard pathway to ensure that the patient scan goes as smoothly as possible with as minimal distress. It also means that having met the patient and their family in advance in a virtual setting and have asked all the key questions, on the day the focus can be on the practicalities of running the session rather than necessarily the medical information gathering and consent process. So I think virtual meetings have really revolutionised the way in which we can ensure patients are prepared for their diagnostic imaging when there are issues relating to consent in adults with severe learning difficulties. And it's those patients which form the bulk of our MRI diagnostic work. We've talked about staffing factors, procedural factors, patient factors. I'm going now to talk about some environmental factors. This is a picture of our interventional radiology suite. It's very ergonomic and very well designed if you're an interventional radiologist looking after an awake or sedated patient. Otherwise, it is not. The room is dominated by a big bulky machine. There are large screens which are fragile and can be easily broken. Everything is in the way. Our stuff is in the way of the radiologists. Their stuff is in our way. It's not designed around anaesthesia. There are no anaesthetic rooms. We can't control the IR table without the radiographer's support. Often during the case, movement is involved, i.e. the machines might move during the case, and if there's any of our tubing or wires in the interceding path, then they could be dislodged, damaged, moved as well. So it's really important to have a very thorough team brief, particularly if doing a case that you haven't done before or you're working with someone that you haven't worked with before in this environment. That team brief has to walk through the process. You have to talk about where the radiology team are going to stand, where the machines are going to be, where the machines are going to move, where the screens are going to be. And only when you have that information can you make a decision about where you're going to place your machines, your monitors, etc. You have to be flexible and you have to be pragmatic and change in response to previous experience. What are useful additions to the radiology room? One hugely useful addition that we found is an anaesthetic machine. The same anaesthetic machine and monitoring elsewhere in the trust. Yes, you can get by on TIVA and portable ventilators, etc. But if you have an anaesthetic machine, it immediately provides some familiarity to anaesthetists attending on an ad hoc basis. That's really important to make people feel comfortable. You need consumables, and the anaesthetic consumables should be of the same standard and availability as in the main theatre environment, ideally in the same kind of cupboard or drawer system, and someone needs to take responsibility for that. That is one of the issues sometimes when multiple theatre areas or theatre teams use the same clinical area, ensuring that main theatres, day surgery theatres, research ODPs all have responsibility for stocking up equipment that they've used. Access to drugs and working with pharmacy to ensure the same provision of anaesthetic drugs are available in radiology that are available in the theatre areas, including controlled drugs and neuromuscular blockers. And being aware that staff may be uncomfortable with slightly different ways of working. So our ODPs, for example, are used to having the only key to the controlled drug cupboard. However, in our radiology unit, multiple people have access to that cupboard. And so they may be unfamiliar and a bit apprehensive about working in that style if they're not used to having worked on a ward previously. And portable ventilators and pumps are incredibly useful because a lot of the things that are involved in interventional radiology involve moving around. So moving from one area to another, going to CT, moving in between areas for induction and for emergence. And so having the ability to provide TEVA anaesthesia and having a dedicated portable ventilator which is in the radiology department makes life a lot easier. One particular problem we had when we first started was regarding heating and temperature management. Standard bear huggers that we use in theatre aren't hugely useful in the radiology department. They get in the way, particularly of vascular procedures, and having anything on top of the patient that inflates can really get in the way of the X-ray tubes and the radiologist doing the procedure. So one very useful tip that we have for you is to think about investing in underbody bear huggers, which are very convenient for this application. And obviously there are other environmental things to take into account. So some environments are intrinsically more wrought with hazard than others, so the MRI environment in particular, but that's probably a larger topic that we're not going to get on to discussing today. Moving on to thinking about positioning for these cases. So I learned very early on that the radiologists don't have the same healthy fear of the non-supine position that we do. In fact, they do a lot of their work with patients in the lateral and the prone position without having too many problems, and so positioning for them didn't really seem like too much of an issue when they casually dropped into the conversation that they'd like their renal ablation patients to either be prone or lateral. So based on my anaesthetic theatre experience, I felt that the lateral position would be a preferential option, and I was incredibly wrong. So we're quite happy with the lateral position in theatre because we have tables that support safe lateral position of patients. They have clamps, they have props, we can keep someone nicely and secure in a lateral position. Whereas on a fluoroscopy table, on a CT scanner, there are no such clamps, and keeping patients safely in that position is very difficult. You could potentially use a beanbag, but these are very cumbersome and they take up valuable space in the CT aperture, so they're not really a solution. Actually, just having the patient prone is probably the better option, and virtually all of the renal ablations we've done involve proning a patient onto a Montreal mattress. It's much easier for the radiologist to do that procedure because the spatial awareness is much more straightforward, and it's much safer to keep a patient strapped on a CT table prone than it is secure in the lateral position, in my experience. So finally, I'm just going to talk about pre-assessment and recovery. So regarding pre-assessment, patients that present for these lists are often those with multiple comorbidities and those who would most likely benefit from minimally invasive treatment. The minimally invasive option might actually be the only option that is sensible to offer these patients. And you don't want to find out about this on the day. They need a time for counselling, risk stratification, an ability to discuss and think about their options, and an ability for us to plan for higher levels of post-op care. Just because the procedure is minimally invasive doesn't mean the anaesthetic won't be without risk. So I think pre-assessment is a very important thing for these patients, and certainly when we embarked on our interventional radiology journey, it was something which we overlooked initially, and I wish we'd had that embedded within the business case from the very start, as having things added onto business cases, as I find it, is a much more complex procedure. And at the other end of the perioperative journey, recovery. Recovery is essential to these sessions if you want to get any degree of productivity out of them. So you must make sure that recovery is factored into the business plan. With our initial MRI service, we didn't have access to recovery. We recovered each patient individually, and that meant we were probably doing one fewer patient than our capacity allowed. With the new business case and access to recovery, we have a much higher turnover and much better utilisation of this very valuable resource. The other barrier that I wanted to talk about, or issue, is regarding patient ownership. So traditionally, both anaesthesia and radiology are seen as support services. IR has no junior colleagues out of hours. They may not have admitting privileges. So it's important to think about who's going to look after these patients and take ownership once the procedure is done, and not to assume that they think it's you and you think it's them. So having an ability to admit under a parent team is very useful in a lot of circumstances where anticipated or even unanticipated overnight stay is something that is a very real possibility. So I've talked about lots of barriers and potentially some solutions. I just want to end on a slightly more positive note and thinking about collaborative working. One of the advantages of working in groups that you don't normally work in is that you see things from different sides, different angles, and you can provide advice and support into other people's specialty, and they can provide advice, insight and support into your specialty. And I want to highlight a couple of the QI projects that we've done in our short time working in interventional radiology. Having regular sessions has provided improvement in the acute setting. So having the facilities there for the elective sessions means that they're still there in the acute setting, and that has provided a huge improvement to our ability to look after patients having emergency treatment out of hours. Also provides controlled access to training in the suite. So if someone is unfamiliar or reticent to support radiology out of hours, they can come and spend some time familiarising themselves with the personnel, the layout, the equipment during a much controlled fashion during the day. One thing we've taken on is upskilling the radiology nursing staff with recovery room competencies. So a lot of the staff in radiology are trained to provide sedation for patients, but when complications happen, they often rely on the emergency medical response team to help deal with those definitively. By providing access to theatre recovery and to theatre areas, we've managed to bring some of these interventional radiology nurses into an environment where they have had first-hand experience of looking after patients who require oropharyngeal airway insertion, face mask ventilation, and they're becoming more used to removing airway adjuncts at the end and looking after the patient with obtunded reflexes. Therefore, we've potentially improved the skills of the people working in that area. And then the final thing that we've done, which has been quite useful, is introducing regional anaesthesia. So most of this talk has been talking about general anaesthetic options. However, some of these things can be done under regional blocks. Interventional radiologists have the entire skill set to provide regional anaesthesia to patients, providing they know what to put where and how to deal with the complications. One of the big barriers to performing critical limb ischemic angioplasties for patients is their ability to stay still or keep their foot on the bed because of intractable foot pain from their ischemic foot. However, we've been able to teach the interventional radiologists to do popliteal nerve blocks prior to angiography and angioplasty, and this has improved success at sedating these patients and provided the patients with a better quality experience. So hopefully this has provided some food for thought, and wherever you are along the journey to implementing the service within your trust, hopefully these experiences that we've talked about today will be some help moving forwards. I'd be happy to take any questions later on in the webinar, and would be interested in any comments or experiences you might have in setting up a service and any pearls of wisdom you'd like to share. Thank you.
Thank you, Martin, for that very detailed presentation.